Hello and welcome back to the LSE Future of Humanity Summit. There's perhaps no existential threat more present in the public consciousness at the moment than that of pandemics. So in our next panel, we'll be looking past COVID-19 on how we have learned lessons from this pandemic and what lessons need to be applied in the future, not just in the case of pandemics, but on healthcare as a whole. Chairing our discussion today is Professor Jonathan Birch, who's an associate professor in LSE's Department of Philosophy, Logic and Scientific Method. He specialises in the philosophy of biological sciences. So I'll hand over to you now, Jonathan. Thank you.
Thanks very much, Joseph. And welcome everyone to the LSE Future of Humanity Summit and to this panel on looking beyond COVID-19, natural and engineered pandemics. The LSE exists to look backwards, to understand the causes of things, and to look forwards to shape the world. We urgently need to be looking in both directions because the next pandemic might be coming at us much sooner than we want to believe. If you cast your minds back to 2019, governments around the world recognized pandemic influenza as one of the greatest threats they faced. In the UK, we had an incredibly detailed pandemic influenza preparedness strategy. That risk hasn't gone away just because we've been living through a terrible pandemic of a different respiratory virus, a coronavirus. The threat of future pandemics remains. We need to think about how we can manage that long-term risk. So we'll be thinking in this panel about three big questions. First of all, what can we learn from the experience of COVID-19 over the past year about how we can prepare for future pandemic responses? Secondly, how can we vaccinate the world and how can we overcome the twin challenges of vaccine hesitancy and vaccine resistant strains? And thirdly, what, if anything, can we do now to reduce the risk of new pathogens, including pandemic influenza, emerging and potentially leading to pandemics that are even more terrible than the one we're living through now? And it's a real pleasure to be joined by three panelists who are as well placed as anyone in the world, really, to help us think about managing those risks. They are Professor Neil Ferguson from the Imperial College COVID response team, Baroness Dido Harding, the leader of NHS Test and Trace, and Professor Andrew Pollard, director of the Oxford Vaccine Group. Now let's go straight into that first question. I mean, first of all, thanks very much to all of you for joining us. I personally greatly appreciate the effort you've all been putting in over the past year to help us try and manage COVID-19. I'm sure everyone watching this is grateful as well. If you are watching this, by the way, at any time, please do, we'd love to hear your questions. Please type any questions that occur to you into Facebook. They'll be passed on to me. We probably won't have time for all of them, but we'll take a selection of them. But I want to start by putting this question to all of the panelists. What's the single biggest thing that wasn't in place a year ago when we were all hit by this new respiratory virus that you wish could have been in place and that you think should be in place in time for the next pandemic? Let's start with you, Dido.
Well, I think my first reaction is it's dangerous to think that there is one single thing. I think we have all learned so much over the course of the last 12 months. And I've been doing a lot of thinking over the last few weeks, but also knowing I was coming to speak here at the London School of Economics, and also thinking about the parallels with other crises, and particularly with the parallels of the 2008 financial crisis. And I think one of the things that, and there are parallels both on the way in and on the way out. I think that the financial crisis taught us that global balance sheets were A, much more complex than we thought we understood, and be much more interconnected. And I think that COVID is teaching us that, that human interaction is much more complex and much more interconnected than we really probably all acknowledged, as are global supply chains. And so that's on the way in to both 2008 and to COVID-19. On the way out, I think we need to be thinking about some of those lessons learned post 2008 financial crisis, the establishment of both global and national oversight of financial stability, and really thinking about how as a country and as a world we manage the long tail risk in the way that the financial services world thinks far more deeply in a much more structured way, with both the institutions, with both the mandate, the powers and the culture to intervene to manage those financial long tail risks. And at a very, very high 50,000 foot level, I think that's the big learning to take out of this, that we need to think, you can't just do this nationally, you have to look at it internationally, globally, but really how does, as a world, do we manage the long tail financial security risks at the top table rather than only in the health family?
And Neil, you were at the table, on Sage, as some of the huge decisions that have shaped all of our lives were being made. If you had to pick one thing that you would have liked to be in place and wasn't?
So I think there's a couple of issues. One is the global response to this pandemic, I think, surprised everyone. It wasn't in the playbook. In some sense, we had played through, simulated, looked at what the capacity would be needed to do this, containing a pandemic at source, doing effectively what was done when you have a small, relatively small outbreak. SARS, the original SARS, could be described as a small compared with COVID, or an Ebola epidemic, where you try and snuff out that epidemic. But nobody had ever conceived of, frankly, attempting to stop a truly global pandemic of something with the characteristics of this coronavirus in its tracks. And basically that's what the world decided to do in various times. China back in January, but then Europe in March, many other countries. And that surprised me, frankly, because in some sense, an incredibly bold choice. I mean, and you're, in order to save the health system, you are going down a course of action which is inevitably going to be hugely economically expensive and costly and socially costly, and that's what we've seen. So in some sense, it's a remarkable choice the world made. It's not a choice which has ever been made before that I know of. And so in that new paradigm, we adopted it ad hoc, as it were, based on good evidence, but we had nothing in place really prepared for implementing that sort of policy. I think there are many technical lessons learned. The biggest one is around having the ability to scale up a testing infrastructure in order to get a handle on how much infection is both coming into a country and is within a country at an much earlier stage than we were able to do. We really only got the first good systematic data around 13th of March from hospital surveillance in England. If we'd had it a month earlier, I'm sure decisions would have been made earlier and perhaps different decisions would have been made.
Is it fair to say you were operating in a kind of fog, I suppose, where the sort of data that would have actually allowed you to time the sort of interventions that were eventually made just wasn't available?
Yeah, I mean, there were impossible decisions being made. I mean, when you can only run initially a few hundred tests a day, then even a few thousand, then you have to decide, are we going to concentrate on screening travellers coming in from the highest risk destinations? And of course we got those wrong, because we were focusing on people coming from China, from other areas with known infection, whilst of course an epidemic was building in multiple European countries in February, which nobody knew anything about. Or do you focus on, in some sense, give up on the borders and focus on sentinel testing in hospitals or GPs? Those were the kind of, given the lack of capacity, those were the rather difficult, in some ways impossible decisions that people like Chris Whitty and Public Health England were grappling with.
Do you think the kind of test and trace infrastructure that we now have is the sort of thing we need to keep permanently, so that if new pathogens emerge, we can quickly scale up testing?
I think we need a capability, and that's partly a technical and platform I mean, a technical capability for, say multiplex testing and being able to rapidly scale testing. We have a lot of labs in the country which can do PCR testing, but actually turning it into as Dido will say in a moment, turning it into a well-coordinated system which can do high throughput testing is a very challenging thing. So I think, I'll let Dido comment on the balance of that. Clearly, we don't want to be running something which costs 20 billion a year forevermore on the off chance we're going to have a pandemic, when they probably are of this scale 1 in 100-year events. But we do want to have a long-term memory of how to do it very quickly, and certainly much faster than we achieved this in the last 15 months.
Yeah, so what do you think about this question of scalability, Dido, that when you got into NHS test and trace, you probably weren't thinking of it as a permanent or even long-term operation, but maybe something like that needs to be retained permanently. What do you think?
Well, I agree with the way that Neil has phrased it. So, 80% of the costs of test and trace today are testing, and 80% of the testing costs are variable based on the number of tests that we do. So the good news is you don't have to spend the huge sums of money that we're spending now forevermore, because we won't all be, sticking swabs up our nose twice a week for forever. So it's the vast majority of the enormous cost is in the variable number of tests you conduct. But the piece that we had to build from scratch was the infrastructure, and particularly actually the digital infrastructure that connected individuals doing their tests all the way through laboratories to a sort of central data brain. And I think that fundamental, both sort of digital and physical infrastructure, is one that we do need to make sure that we leave as a lasting legacy. And it's not one that needs to lie idle at all. It's one that I would hope to see become an integral part of a 21st century diagnostics network for multiple pathogens, multiple infectious diseases that you could then use to scale up very quickly, either locally, regionally, or God forbid, nationally and globally if you had to, for another pandemic. The piece is, a number of people have said this before me, but it's much easier to scale something that already exists than it is to have to build something from scratch. And what the team who what Neil describes the times in February, March and April before I arrived, the very early pioneers who were starting the national testing program from scratch, where the country could only do a couple of hundred tests a day. Now we know, when I arrived in early May, people were saying we can't conceive of being able to do more than 100,000 tests. In fact, people were very skeptical about the ability to get to 200,000 tests a day. Well, last week we were averaging about 1.5 million a day. So we know how to do it. It's how we make sure we leave both the physical logistics flows and the digital capability, so that if you do need ever to scale up again, you can. And that won't come at the sort of price week in, week out that we're paying now, thankfully.
That's good. Yeah. I mean, there was this line in the Sage Minutes from February where it said it was impossible to have COVID-19 testing running alongside regular flu testing in time for this winter. And so some of that thinking about what was possible or not has really been blown out of the water, hasn't it, by developments since, in that we've shown that mass testing is possible to set up incredibly quickly. And so that would change dramatically, wouldn't it, the way that people think about approaches to new pathogens in the future. I guess it would just change a lot of the thinking around the whole issue.
And necessity is the mother of all invention. I know that's a trite saying, but I think what we have seen, and sort of Andrew and his team in Oxford are one of the shining lights of that. We've seen phenomenal science-led innovation. And when we get the sort of overlap of our brilliant academic institutions, the commercial sort of industrial life sciences and diagnostics industry, and our fabulous free at the point of need healthcare and public health system, when you get those sort of three institutions all overlapping and a burning need to drive innovation. We've proven in this country that we can make huge change very, very quickly. And that's something that we mustn't forget either. And working out how we capture that secret sauce in more normal times and that we don't just all go back into our own silos, I think that's also something for us all to reflect on and going forward.
Yeah, I think on this topic of driving huge change incredibly quickly, let's bring Andrew in on this, because the Oxford AstraZeneca vaccine has been, on the face of it, this extraordinary success that a year ago we were talking about, will there be a vaccine in 18 months or might we be waiting 4 years? And pessimism about a vaccine arriving very soon was guiding a lot of the policy responses and leading to pessimism about the idea of really being able to contain the virus until a vaccine. And it's just happened much quicker than we thought possible. And do you think this is in some sense a one-off, or do you think this is something that we could actually repeat and that vaccines now are just much, much quicker to produce than we thought in the past?
Yeah, I mean, I think there's a few things, and reflects to your last question as well. I mean, if you're absolutely right. I mean, it's been an unprecedented speed of development to reach a point now where not just our vaccine, but with all of the vaccines developed, up until the end of the week we've just had, 500 million doses have been deployed around the world. I mean, that's just astonishing to reach that point. I mean, it's still a long way from the 7 billion people on the planet, but that is just amazing. However, when you look at the UK with over 120,000 deaths, if just a few months quicker could have been possible, that's a lot of lives that might have been saved. And I think it's something we really ought to reflect on, is where are the areas that might have speeded up that process to get us there more quickly. And I think one of the issues is about capacity, and we talked a bit about test and trace and so on. It's true in every aspect of the vaccine development program as well. What capacity is there at the beginning for here within the UK, the number of different types of vaccines available, vaccines that were available in academia. There wasn't very much that was here, despite very good investment in vaccine R&D over the last 5 years particularly, but we didn't have a whole portfolio of products. We have very few institutions focusing on vaccine development. And so that's one issue, is could we have had broader capacity there? Capacity for the raw materials to go into everything from manufacturing to clinical trials really was a major challenge moving forwards. And then just the capacity to run the scale of trials. I mean, you can get an answer quicker if you can run bigger trials. If our trials have been 100,000 or 200,000 people in phase 3, stood up really quickly, we'd have had an answer possibly months earlier than we did. So I think that's the one thing I would reflect on, is that going into it again, you might say, well, how could we generate bigger capacity? And I think one of the real challenges is that in a small academic setting, in a university, it's very difficult to run high quality studies on the scale that would be needed to get an answer months earlier than we did. So I think an incredible success story, but definitely capacity is something we need to go back and look at again to think how perhaps could things have been done differently. I think there's one other aspect that we should just briefly reflect on, which is that, as Neil was saying, we're dealing with a coronavirus that we've already dealt with 2 outbreaks of coronaviruses over the last 20 years. We know the biology of these organisms. We know how to make vaccines against them. We know that the spike protein's the key target for the immune response. But there are many other pathogens out there, bacteria and viruses, which we just do not have that level of understanding about. And although this has been a terrible pandemic, we have been rather lucky that we had so much insight from the beginning about how to make vaccines.
The same, I would say, is true of the epidemiology as well. I mean, yes, it isn't pandemic flu, but in many ways, epidemiologically, it wasn't too dissimilar, or at least a cross between that and other respiratory viruses such as MERS, and that also informed the non-pharmaceutical interventions which were deployed. You could well imagine some pathogens which would have been much harder.
And Neil, can I ask if you think the initial response was perhaps too reliant on assumptions that had been drawn up for pandemic influenza. For example, in the pandemic influenza plan, there was this line about how it will not be possible to stop the spread of a new influenza virus, and it would be a waste of resources to attempt to do so. Do you think those planning assumptions perhaps led to people writing off the idea of containment too soon?
But containment it depends what, I mean, you mean by containment. Containment at source was always on the table, but as I said in my opening remarks, that, I mean, there has been a paradigm shift. I mean, the reason that was in the pandemic plan was because at the time, I think Sally Davis was the chief medical officer at the time, but when people looked at it as a policy option, we knew it could potentially work. I mean, it had been done in US cities in 1918. Certain communities did respond to the 1918 Spanish flu and try and stop spread, and they succeeded in doing it. But only whilst those very draconian interventions were in place, and those came with enormous economic cost. I think the paradigm shift has been, the world has moved to a stage, and where societies across the world have moved to the stage where it is not, almost regardless of the cost, it is not acceptable to let health systems fall over and millions of people die. In this country, it would have been many hundreds of thousands. And therefore, we as a society felt it was a cost worth paying. Not everybody in society did so, but the majority. That is the paradigm shift. It was just previously viewed as just too expensive.
So you think there was a stage in which Sage was thinking about what was politically possible in the wrong way, that things that were being described as draconian and they'd never really do that were in fact options, but it wasn't clear they were genuine options until late March?
Well, I mean, I don't think Sage took much notice of, I mean, the role of Sage is to offer scientific advice to government and a range of policy options, saying if you do A, this is likely to happen. If you do B, this is likely to happen. It's not our role to kind of really judge what's politically possible, a little bit to judge what is technically possible and the level of evidence supporting it. But we had evidence really quite early on. I mean, from what was going on in China, for instance, and then what went on in Italy, northern Italy, that these measures would likely work. I think the real challenge was, were they necessary? I mean, and that is intrinsically quite a difficult question to answer. It is partly a political and economic question as well as a health question. I mean, what are the costs and benefits? And so, yes, time was spent, is there any other option but, suppressing or locking down? Can we do anything else? And the conclusion of that analysis from multiple groups and multiple perspectives was no. I mean, the best we can do short of trying to suppress spread would have been catastrophic in terms of the impact on the health system and the number of deaths caused. I mean, more than twice as many deaths as we unfortunately have ended up seeing. Yeah,
I'm really interested in this question of whether the scientific advice can be purely scientific without some political judgments involved.
I mean, yes, there are
some political judgments.
Yeah, I mean, it is there's always a little overlap, and different scientists have different perspectives. I mean, I've personally taken a perspective that, I mean, I've been fortunate in, people listen to what I say, but as a scientist, I don't have any greater right to determine policy in the country I'm a citizen of, never mind a country I'm not a citizen of, than anybody else. What I can do is try and explain the science and explain, therefore, if a government decides to make this policy choice, then this is likely consequence. And if they choose something else, that's the likely consequence. I don't ever felt it's my role to go on the radio and say the government needs to do this. I mean, sometimes you get a little bit close and say the government might want to consider the risk, for instance, from new variants from France or whatever. But at the end of the day, it's the government's decision.
There was a moment, though, wasn't there, where there was that extraordinary paper, 16th of March, the big modelling study that showed we were heading for total disaster if there wasn't a lockdown and school closures.
And I agree. And that got close in the sense that we concluded that just because of the level of impact on the health service, there wasn't really any other option but to I mean, and we carefully called it suppression, a suppression strategy based on social distancing. There were political choices from that point onwards, though, between, in some sense, a Swedish-style, more voluntary-driven lockdown and a mandatory lockdown. We went into the latter because by the week of the 16th to 17th of March, we realised that, well, we had about 3 weeks left until London hospitals were overwhelmed. But even within that kind of scientific conclusion that, yeah, we do not want a health service falling over for 6 months, which would have been the other option, then there are still political choices to make.
Yeah, I mean, I think it was absolutely right that in a way you took that political choice into your own hands up to a point by saying, look, we have to close schools now. We have to do this now. Seems if there was ever a moment for a scientist to actually say that.
Yeah, but you also have to bear in mind that, I mean, the government, there was nothing in that document which the government didn't already know. I mean, in fact, the pressure at the time was to get the modelling out into the public domain. Both ourselves and the London School, my colleague and friend John Edmonds and their team did just as much as we did, saying, and that had been going into SAGE and into government for weeks before. So there can be a kind of external misperception of the importance of any one report. In fact, most of those discussions predated that.
Great. I mean, let's bring Dido back in, I think, in terms of, I suppose, the story of a bit later in the year, because we're thinking about the initial response and that dramatic decision to lock down in 23rd of March. Test and trace at that time was sort of nowhere. So if you had symptoms, there was no way to get tested, and then it very quickly sprang up later in the year, and in a way has scaled up at extraordinary speed and defied expectations. At the same time, there's still been a bit of debate about how effective it's been, with SAGE expressing some skepticism about its effectiveness and, you know, in comparison with lockdowns and things like that. So Dido, how effective do you think test and trace has been in this country, and what might have been done to make it more effective?
I think you should be asking the effectiveness question to an independent scrutineer like Neil, rather than asking me to mark my own homework. But I can tell you what it has felt like, and so, you know, just put some context around some of the stats. So as Neil said, that sort of fateful time, this time last year in March, the country could do 2,000 tests a day just. And we launched NHS Test and Trace at the end of May, when we had the capacity to do 100,000 tests, and we recruited about 25,000 people to stand up a contact tracing service that launched at the end of May. Since then, we as a country have conducted more than 100 million tests in that sort of 9-10 month period. We've reached 9.2 million people and asked them to self-isolate. And the latest data that we have, and assessing how a test on its own isn't hugely useful. It's at breaking the chains of transmission. It is useful data to help policymakers, both locally and nationally, hugely useful to decide whether they have to impose restrictions. But individual testing on its own is only effective at breaking chains of transmission if we reach people that person who's tested positive might have infected, and they all self-isolate. And assessing how effective any system is in self-isolation in a liberal democracy such as ours depends on people self-certifying how they've been behaving. So any assessment we have in the end of the effectiveness of test and trace is a function of the effectiveness of our ability to understand isolation behaviour. And we've been getting better and better at that through the 9 months as well. And ONS this week published for the first time a reasonably large survey that we've commissioned from them to assess that, but it is still based on people's self-reported behaviour. So I say that with huge caveat. What that says is about 85% of people are complying, or say they're complying and believe they are complying, which is much better than I think the sort of media narrative would have us believe, but isn't perfect. far from perfect. And often the people whom it is most important, we do support them to isolate, are the people who find it hardest. So it's at the, there's been a lot of focus in the last 9 months on the testing and the tracing part of as we built the infrastructure. But in the end, it's a meaningful intervention if it changes individual behaviour on the ground. And there, as I say, I think we're doing much more as a country, individuals all adding up, our societal behaviour. I'd be really interested in Neil's view on this. Our societal behaviour, I think, from the very beginning has surprised on the upside on all of the assumptions that people have really tried their utmost to comply with these extraordinarily strange restrictions that would have been unimaginable 14 months ago. But that's not to say that it is equal and even. And I think as we look forward, the next sort of 6-9 months, it's increasingly clear to me that we've got this scale test and trace capability, but actually we need to learn how to really adapt it to support often the most disadvantaged, disenfranchised communities in the country. COVID has really laid bare the health inequalities in our society, in the world arguably as well, and making the great big sort of machine that we've built really work for everyone rather than just for the averages. That's what will help us navigate the next phase of the pandemic as the vaccine program starts to really work its magic. The way that we really exit lockdown smoothly is going to be making sure that both the vaccine program and test and trace reaches into every community in the country. There, I think we've got more work to do.
Yeah, Neil, do you want to answer that question about how compliance has related to your own expectations?
So actually it's been higher generally. I mean, in the original modelling we London School did, I mean, we didn't assume such high compliance with isolation, household quarantine. I think we were assuming something like 75%. I mean, just a couple of points about test and trace overall. First of all, as well as just individual contact tracing and isolation of contacts, largely in the household, but in other contexts, I think the other major thing test and trace has given us is an ability to what the South Koreans would call cluster detection, detecting clusters of cases associated with, for instance, with a particular school, a particular workplace, a particular environmental context. And that's been very useful information for local health teams and management. The other thing is, right now, the UK has probably an unparalleled COVID surveillance system in place, not both the test and trace, but also antibody testing, through serology, the infection surveys, very good health system information. We've built an infrastructure which is unparalleled and gives us an unparalleled detailed real-time view of this one disease. And if there was one thing which I'd like to kind of retain and extend, is that digital infrastructure, that hooking in the data. We need to reap the benefits of that in other health contexts and in other societal contexts more broadly, because we've never had it at that level of granularity in real time for any other disease before. I also completely agree. I mean, because of that detailed view we're getting, I agree with Dido's comments that it has revealed the level of health inequity in the country, that the poorest in our society have been most exposed, have the highest prevalence of pre-existing health conditions, have had the worst outcomes as well, have the least access to reliable information and the least ability to isolate. So the tragedy at the moment is those communities in the UK with the lowest uptake of vaccine, the greatest vaccine hesitancy, are also the ones which have been worst affected by COVID, unfortunately.
Yeah, I mean, before we come on to that topic of vaccine hesitancy in more detail, and there's maybe a couple more things I want to ask you, Neil, about the response. I mean, first of all, do you think there's a sense in which the response should have been more precautionary? Because we hear a lot about the precautionary principle and so on. And if we look at countries like New Zealand, where they really, stopped all travel coming into the country at a very early stage, should we have been looking more along those lines, and should we in the future aim to be more precautionary in the way we respond to pandemics?
I think that's a difficult. So we're not New Zealand. I mean, for us to have sealed our borders, we would and keep the virus really out, we would have had to basically do so certainly by mid-February at the latest. So I mean, and that just wasn't. I mean, yeah, wasn't conceived of. And for a country as globally connected to UK, I mean, I'm still not convinced it would have been a feasible policy option. I think there are things which are about responsiveness, and about being proactive, which unfortunately the lessons weren't learned anywhere in Europe. And that is around the nature of exponential growth, the fact that if you are going to adopt a suppression strategy to stop an exponentially growing epidemic, it is always best to do it earlier rather than later. And so, in some sense, this false dichotomy was created, that we were balancing how much we control spread against economic freedoms. And I think it's been proven to be a false dichotomy. If we go back to certainly back to spring of last year, but it's really the autumn of last year that I think the lessons we have now learned is if you respond earlier, you get a control of infection earlier, and the controls don't need to necessarily be in place any longer. You just maintain, you can switch them on and off, but you maintain infection levels at a lower level. It's only part of the picture. I mean, it's easy to overstate it. And we were also very unlucky with the Kent variant, which has accounted for well over half of the deaths we've experienced now, and took off in a way which no one could have anticipated.
Yeah, I mean, do you think that there were lessons that could have been learned by the autumn, but were not? Do you think, in fact, that the government became less responsive to scientific advice in the autumn?
I mean, I think that is more in government than I mean, I think there was a complex and more fragmented political discourse going on, and let's put it neutrally like that, which made it harder to get the message across. I think also back in March of last year, everybody could see the public health threat posed by COVID. Hospitals full in northern Italy. Everybody realised the magnitude, nearly everybody recognised the magnitude of threat. By late summer, early autumn of last year, people always also recognised the economic costs which came with, and social costs which came with those sort of control measures, which had always been anticipated both in the science community and by government ahead of time, but they were very apparent to everybody. So understandably, a certain section of society was very reluctant to move back into those sort of measures. The tragedy is, had we done so earlier, in a kind of sustained way, we wouldn't have been in them for any longer. The economic and health costs probably would have been lower.
Yeah, Dido, do you think the government became less responsive to scientific advice in the autumn?
No, I think Neil puts it, so I'm in danger of just violently agreeing with Neil. I think that the problems have got more complex to solve as the costs and the challenges of any of the routes have become clearer to everyone. These are very, very difficult problems to solve. And you look across the world and, we can talk about how this would have been easier to handle if in January, February last year, we'd had the data to really understand that, had that surveillance data in place. Then you're in a position where the choices are just smaller choices. But once you've reached the point of the high levels of infection that we had, even coming out of the summer, I think it's a very human thing not to understand the impact of an exponential growth curve. And at the core, that's the problem that we're facing. That it's, as Neil says, it's very clear that if you act early, that it isn't a trade-off between controlling the epidemic or economic freedom, but really emotionally accepting that is a very difficult thing to do for an individual human being and for society as a whole. And I think that's the conundrum that democratic governments have faced the world over and are facing right now as we look across the channel, for example.
Do you think there should have been more deference by politicians to scientists? Because of course the scientists here do understand exponential growth, and there's no question of them being overcome by emotions or anything like that. Do you think there should be, in this sort of situation, should politicians say, scientists, you say what to do?
I think, as the non-scientist on the panel, I think deference is a bad thing in science. And it's important that actually what you need is fierce debate. And that's really important, both in science and in democracy. So I think one of the things that the Joint Biosecurity Centre that works for me, that is the sort of the brain of NHS Test and Trace, and aggregates and analyses all of these extraordinary pools of data that we now have. They have a fantastic phrase about working in stripy teams. It's a way of describing the diversity of thought that you need to try and solve this problem that crosses so many scientific and social science disciplines. So no, I don't think deference from any of us is the right answer. I think it's important that we're listening to each other, and in a democracy, respecting the job that the politicians also have to play, which is to bring the nation with them. And in the end, if there's anything I would want to defer to, is that democratic principle. I fundamentally believe that's the right thing to do. And for those of us that are providing technical services and advice to government, that we're loud and strong in that, but in the end, we defer to the democratic principle in the public.
I think one other thing that's just worth mentioning here is that often the scientific discourse is presented as scientists arguing with each other. But of course, what we're observing when we see scientists apparently disagreeing with each other is the scientific method, which is you make a hypothesis and then it has to be challenged. And that is the only way that we test our hypotheses. And I think that's very often been framed over the last year as disagreements between scientists, where actually I want to be challenged when I put my data out to make sure I've got it right. That's absolutely the fundamental principle in science. But that's very difficult from a public communication perspective, where disagreement actually means there's disagreement.
Yeah, I mean, Andrew, can we talk about vaccinating the world then? That the rollout of the vaccine in the UK has been astonishingly fast. It surpassed all expectations, just like the development of the vaccine in the first place. At the same time, distribution of the vaccine globally is extremely asymmetric, and it seems very likely that relatively young people in Britain, like me, will end up vaccinated well ahead of clinically vulnerable people in other parts of the world. What can we do about that? What's the future of vaccinating people against COVID, and how can we try and get more equality around the world?
Well, I think it's a huge challenge. Some of those global mechanisms are now in place. There's the COVAX facility, which is distributing vaccines to low and middle income countries, really with that activated from towards the end of February, with the first doses being delivered. That's at this moment still quite patchy. We don't have very many vaccines that the World Health Organization has approved that can be distributed. In fact, the largest bulk of vaccines is the one we developed that is being distributed at the moment, with very little from any of the other developers. And that's partly because they're not approved by the World Health Organization, and partly just because the supply isn't there yet. And so that I think is the biggest challenge, is actually having enough supply for the number of people that there are who are in vulnerable populations. And I think the difficulty is that I guess it's inevitable that the countries where there is greater access to the manufacturing facilities and the development have made sure that the bilateral deals with industry are in those countries. And it's much more difficult for many other countries in the world with none of that capacity to do that. But I think we are in a better place than we have been almost ever in history, where there are these global mechanisms to make that a bit fairer than it would have been normally. And I think COVAX is the best example of that, where we're not in a position where it's years later before the poorest countries receive vaccines. Some of the poorest countries have already been receiving them ahead of some of the rich countries. And I think that's fantastic. But you're absolutely right, it's asymmetric. The UK, countries in Europe, North America are doing much better than many others. Perhaps another way of looking at it is that perhaps we should be thinking about where the greatest need is. And at the moment, it's absolutely clear that that is this increase in disease in Europe, what we're seeing also in South Asia with an increase in disease, and in parts of Latin America, and particularly Brazil. Should we be thinking a different global strategy where we're focusing perhaps supply at this moment to areas where the greatest need is? So I think I would move to a focus on vaccinating the vulnerable in different populations first, and that will be older adults and those in high clinical risk groups. And trying to work out how you do that from a global perspective, I think, is a critical part of what we should be doing. And I think the difficulty in this is the both political decision making which happens, but also there are commercial interests. And one of the reasons why our partnership with AstraZeneca was all about not-for-profit, because we really didn't want to be in a situation where profiteering in the pandemic drove the decision making about how you distribute vaccines. And I think we're all here very proud of that fact.
Do you think it's in our interests, in fact, for Brazil, for example, for vulnerable people in Brazil to get vaccinated? Because the more the pandemic rages through other countries, the more we can expect there to be new strains.
I mean, I think there's several different things at play here. I mean, the pandemic, if you focus on the older adults and the vulnerable, is not going to go away. There'll still be lots of transmission and chance for new mutants to arise. We're not going to have enough vaccines in the next few months to be able to stop that happening. So I think this is much more about, if you protect the elderly, which protects health systems so that the people aren't going into lockdown, you benefit the global economy hugely. Because the only reason why we have a pandemic is because our hospitals are full. If it was a pandemic of people with respiratory infections that were mild, then we wouldn't be in the position that we're in. Now, no, it's not true to say that all young people are safe, because that really is not the case. But the largest burden on health systems is older adults and those with other health conditions. And so that's where we really need to be focusing doses. But Neil's probably in a better position than me to consider this issue, because it's really a modelling question. Is what would you best do with a limited supply?
Yes, and we've looked at it. I mean, there are moral and ethical and political choices laid on top of all of that as well. I mean, yes, right now, I mean, just looking at the data, I mean, Brazil is, looking truly dreadful. I mean, they're heading for 400,000 deaths, and they're now up to 3,000 deaths a day. So they have a very urgent, immediate need for vaccine. Unfortunately, part of the reason they're heading for in the state they are in at the moment is government decision making and political leadership in that country having frankly let down the population of that country. And so and this is in the paradox that actually Brazil is a middle-income country with quite a substantial vaccine manufacturing and production infrastructure itself. So I do actually think, it's a lot of the middle-income countries which right now are in the most difficult position. They're not getting international support through COVAX for buying vaccines. They can't necessarily compete in the international marketplace, and they're seeing, in some cases in Brazil and Mexico, really catastrophic second stroke third waves of transmission. Same is true in some areas of South Asia, Indonesia, for instance, and other countries. But I don't pretend to have the magic wand which can make the world a fairer place, unfortunately.
And I think in Brazil specifically, there is supply of vaccines from China. There's also a supply of our vaccine in Brazil, and the number of doses is actually being ramped up at the moment. So, but it's a huge country. It's, even having millions of doses, it takes a long time to protect a population of that size.
And Andrew, can I ask what you think the long-term prognosis for the world is, I suppose? Because one of the fears here is that somewhere in the world, vaccine-resistant strains will evolve that will evade our current vaccines. And so we'll develop some booster for the rich countries, and we'll have boosters every year. But the idea of giving everyone in the entire world a booster every year doesn't seem very plausible. I mean, that's a bleak picture. Are we heading for that bleak scenario or not?
Well, I mean, there's a number of scientific uncertainties in what you've just said. I mean, the first is what will the virus do? I mean, it seems most likely to me that the virus will continue to evolve over time and escape from human immunity. I think the 𝗣𝘀𝗏 variant probably arose because it transmits better rather than because of evading immunity, because it arose in a region where there was relatively low levels of immunity in the population. But if you look at some of the other variants, and the P1 variant in Brazil, the B.1.351 in South Africa, they very clearly are emerging because they can escape from the immunity from previous waves of infection. And I think that is telling us that the virus, obviously for it to survive, it has to be able to escape from human immunity. And the scientific question is whether it can continue to do that in the face of vaccine immunity and escape, so that it continues to transmit in populations. It does seem likely to me that that will happen, but it's not for certain yet until that's there. But I suspect the fact that the viruses will be with us for decades to come, causing respiratory infections. The big question in my mind is not really that, because I think that's the likely outcome, is whether the immunity that we're generating with the current generation of vaccines is going to be sufficient to prevent severe disease. And we are definitely seeing evidence in animal studies, and some of the evidence in these countries that have got the variants is that the vaccines may be able to prevent the very severe infections that put people in hospital and cause death. Now, if that turns out to be true and it's sustained, then we might not even need future new variant vaccines. But all of that is not certain yet. And so at this moment, we have to work on making vaccines for some of the new variants so that we're ready for deploying those if we need to in the year ahead. I think your question about whether some countries will get left behind with that one, if you need a new variant vaccine, at least in the short term, I don't think so, because developers will have to switch their production to the new variant vaccines at some point over the next 6 to 12 months. And when that happens, then the whole world will benefit from those new variant vaccines. So I'm sort of optimistic, at least in the short term, that will be the case. If new variants continue to emerge, which sustain the pandemic over many years, then I think that really is a challenge, because from a global perspective, it's almost unmanageable to keep vaccinating the whole population every year of the world. But I just don't think that that's likely to happen. But let's see. We will have a lot more information in the next 6 months.
It's good to have grounds for hope. Yeah. I mean, what do you think, Neil? I mean, were you surprised by the Kent variant, where it seems as though there's really quite a lot of mutations in the spike protein? I was certainly quite shocked.
In multiple genes. I mean, surprised. I mean, one is always, I mean, these things are unpredictable. So to some extent, we had seen a few instances in the literature of, I mean, particularly variants of mutants arising in immunocompromised chronic infections, which suddenly gained lots of mutations at once. So it didn't come completely out of the blue. But I suppose what surprised me is the extent of increased transmissibility. So the D6, I mean, we've seen this happen before, but the variant which arrived in Europe was different. I mean, back in February, March of last year, had important differences from the original Wuhan strain, which probably increased its transmissibility by 20% or so compared with the Wuhan 20-25%. But the Kent variant was, somewhere between 50 and 80%, depending on context, more transmissible. And that's a huge amount. It's the difference between a kind of R value, but in the absence of any controls of 3 and one of about 5. It makes control much more difficult. It's almost certain that the P1, the B.1.351, the Brazil and South African variants are similarly transmissible, and which is why those countries have experienced, resurgence of transmission. Europe is now where we were a couple of months ago. I mean, they're seeing the Kent variant is what's dominating there. And it just requires control measures to be stepped up.
This is kind of a dark question, but should we be wary about keeping people alive too long in intensive care units with COVID?
I'm not a clinician.
Because that's where the new variants come
Andrew,
from.
who is a clinician.
Andrew, do you have a view on that?
Sorry, what was the point of the question? So,
well, should we be wary about the dangers of keeping people alive in intensive care too long with COVID? Because it seems like that's the most likely origin for new variants.
I think that's not the right way to think about it. The new variants are occurring all the time in all populations where the virus is transmitting. And most of the transmission is actually happening between people who are not in hospital. Most of those new variants that arise are hopeless and they don't survive, they don't persist. It's the occasional new variants like the B117 Kent one, which is happening randomly. These mutations are happening randomly in the viruses. It's not thinking I'll make a variation. It happens randomly. And then when that variation happens, if it then confers a fitness advantage for the virus, like being able to spread better, it can then take over and dominate. And I think one of the things that's really interesting about the current variants that are emerging around the world that are starting to transmit better is that there is what's known as convergent evolution in that they have got some of the very similar mutations, even though they've arisen tens of thousands of miles apart. And of course, the reason for that is that they are responding largely to immunity that was in the population generated by previous variants. So they've had to find the escape route to survive in the human population.
And Dido, can I ask you about this? Because one of the potential of the test and trace system is that it can pick up new variants, like the Kent variant. How much is that part of your thinking at the moment about what this system is for, and what's your plan for detecting new variants as they arise?
Yeah, absolutely. And Neil alluded to this earlier, that the ability to spot new variants, known variants of concern, and to contain outbreaks is one of the core capabilities that we now have. And the UK is in an incredibly strong position in this space. So we do roughly half of all whole genome sequences of COVID-19 in the world. And whereas in the autumn, when the Kent variant emerged, we were sequencing a relatively small proportion of all positive cases. Now we're able to sequence almost all viable positive samples. Not everyone who tests positive, not everyone's sample is of sufficient sort of quality to be able to be sequenced, but we're increasingly now have the capacity to sequence everyone that is. We also have a new testing technology that is a form of PCR test that enables us to test for known variants, for a limited number of known variants, including the B1351 and the Brazilian P1. And that's a test that only takes a few hours to run. So, within a day of someone testing positive, we're able to identify a known variant of concern. You still want to do the full genomic sequence to understand how the virus is changing, but we have phenomenal capability to do that through testing. We also have a testing technology that I think could be something that really will be a future benefit for a multitude of diseases, which is wastewater analysis. That has been another example of the necessity being the mother of invention, benefit of academia, the commercial, industrial side, and local government and national government and the NHS. So we're scaling up the ability to analyse wastewater and to run genomic sequencing on wastewater down to really quite a granular local level. And that will pick up early signs of mutations, possibly before anyone even knows that they're feeling ill because of the amount of asymptomatic transmission. So put all those together, and yes, this is a core part of what we've built NHS Test and Trace to be able to do, and to provide that service both locally and nationally, and would be very much part of the legacy I would hope we'll be able to leave for future infectious diseases.
I think it's worth just adding into that, and it touches on what Neil was saying before, that it's actually the global surveillance that is critical for us. So I think Dido is absolutely right. We've got fantastic setup in the UK for these different approaches and this huge sequencing capacity, which allows us to understand the biology of the virus and to detect mutants. But it's what's going on elsewhere that's so critical. And there are many countries, many regions of the world where there is just none of this is in place at all. And there will be new variants in those areas.
And I would say that we are looking to and have announced our plans to set up an international platform enabling countries that don't have their own genomic sequencing platform to access our capabilities to be able to sequence. Andrew, I totally agree with you that this is another one of my sort of read across from financial services and the financial crash. It's no good us pulling the drawbridge up and saying we're all right. We actually have to support globally because the virus doesn't obey geographies.
And Andrew, can I ask you about vaccine hesitancy? That it seems like take-up of the vaccine in the UK, as far as I can tell, has been very good. But globally, there's a real issue, isn't there, about trust in vaccines?
Yeah, I mean, that's right. I mean, I think the UK, so far, the uptake of vaccine is far better than I think anyone could have hoped for. And I suspect that Neil's had to adjust many of his models to actually account for the actual uptake, which is just fantastic. And of course, those doses are protecting a large proportion of our older adult population as a result. It is true that there is problems with confidence in many countries, some of it pre-existing and much of it not helped by a lot of the political discourse and reporting that there's been over the last year in many countries. And I think this is something which really does need to be reined in. How do you do global communications? It's not just managing within your own country, but global communications in a pandemic that really supports whatever aspect of health that we're talking about, whether it is test and trace or it's the vaccine programs, in a way that sustains confidence. And I think it's one of the things that we will have to learn a lesson from this pandemic about, because there is no doubt in my mind that vaccine hesitancy at this moment will be costing lives.
I go further than that. I mean, I think we need to find a way of communicating, but I think this pandemic has shown how quickly disinformation, frankly, can spread on social media. And whilst we talk about political echo chambers and polarization of politics, that's bad enough. But if it actually relates to things about people's lives and health, it's even more serious. And that's what we are frankly seeing. There, unfortunately, there's a minority of people who are being persuaded or sucked into sets of beliefs and statements on social media which are just patently false, and that's been a problem throughout the pandemic, and it's continuing to grow.
And a lot of that sits in particular communities, and so until you engage with those communities, you don't even know it exists. And I've certainly had conversations with groups of people here locally who have been very concerned about vaccination because of what they're reading in their own community on social media. And I think that this is a really important issue, which we're, I think, only at the start of trying to understand how best to address it.
I think Andrew and Neil are both spot on about this. My background before I became involved in health and the NHS was in telecoms, and I spent a lot of time on child internet safety, and people who've worked in that space have worried for the best part of 15 years about how we don't really have a global approach to making the digital world a civilized place. And what we've seen in the course of the last year is this writ large in a way that, as Andrew and Neil say, is something fundamentally dangerous. And we do need at a global and a regional and a local level to work through how we ensure that we don't just let the digital world be a Wild West, and that we establish the global and national institutions and the rule of law in such a way that people can trust information in a way that is absolutely not the case, particularly in the communities who are most in need of having sort of verified, trusted information reaching them right now.
Do you think we need tougher regulation of social media?
Yes, I do, and I have done for a long time, based on my work in child protection online. Even in areas where you'll find no one coming onto a platform to say that it's a good idea to enable child pornography to be easily accessible. Even in that space, we don't have sufficient regulation, and we're not holding the institutions and organizations that control that data flow to account to make their services safer for children. And that's, you'd have thought, is the area. So you can hear from the passion in my voice, this is something I've worked on for a long while, but now we see it writ large in a on a much broader canvas. And I think it is one of the key things. The digital components, as Neil said earlier, that it's the digital infrastructure that we didn't have that made responding in a number of parts of the COVID response so hard, but it's also some of now, as we've broadened into this topic, the digital mores, the moral, ethical, legal scaffolding for the digital world that is also holding us back in being able to bring the whole world with us on this.
And I think this is a really important component, is that it has to be not just a local regulation, it has to be global. And I think one of the things that's really struck me about the whole communications around vaccines is that you can't just manage it within one organization, one country, because everything that is being spoken about, whether it's other countries in Europe or in Latin America, has an impact all around the world. And I get calls from people in Africa about something that's said in the UK or somewhere else in Europe, to try and verify, people wanting to verify what's the truth. And so we have no control, and maybe that's right, but we have no control of this global communications around the role that vaccines need to have in curbing the pandemic, and without any doubt saving many thousands of lives this year.
Though at the risk of sounding naive, we mustn't let the fact that it's a global problem mean that we don't try and solve it beginning at a local level. I think it's been a very dangerous and invidious narrative that some of the big tech giants have used to say this is a global problem, therefore we're not engaging with you, Britain, on this subject. Actually, as Europe has shown with the regulation in terms of GDPR, actually you make a difference at a global stage by starting often at a smaller stage. And I think that in this sort of space, because of the UK's leadership in life sciences, we should be really using this as an opportunity, our leadership in life sciences and in digital, to push the agenda.
No, I agree.
I think also with the change of administration in the US, we're entering perhaps a more permissive regime. I mean, everybody in Washington is talking about some degree of greater regulation of social media for exactly these same issues.
Great. Good to see agreement across the panel on that. Just a note for anyone watching on Facebook, please keep posting your questions. I'll be taking questions from the audience very soon, but I'd also like to ask the panelists about future pandemics. So what, if anything, can we do to try and reduce the risk of new pathogens emerging? We hear a lot about H5N1 in particular, and the possibility of highly pathogenic avian influenza potentially creating a pandemic far worse than even the one we're currently living through. I mean, let's go to you first, Neil. Is there anything we can do to reduce the risk of new pathogens jumping to humans? And if so, what is it?
So it's difficult to know. I mean, it's likely that the rate of emergence, how frequently we get new pathogens emerging in people, relates clearly to the intersection of animal populations, particularly wildlife populations and human populations. And so things like the bushmeat industry, destruction of wildlife habitats, people moving into those habitats probably increases that risk. But the level causality has not been proven, and it's unclear the extent to which we can really reduce the risk. I think what we can do, and there has been decades of investment in boosting global influenza surveillance, exactly because of this risk, but I think COVID has taught us even more how to do this. We can get a much better early warning system. And to be fair, because of the lessons from SARS, because of the lessons indeed from avian influenza strains in China, we learned about that cluster of pneumonia cases in Wuhan at a much earlier stage than we ever learned about SARS all the way back in 2003. I mean, there are things you can criticize about the early Chinese response, but nevertheless, we had a virus sequence within a couple of weeks or so. But we can probably do better still in that. And that's probably the single biggest thing which we can do to reduce risks. If we learn about things early, we can respond to them, we can put in place interventions around clusters of cases at a point where it's much more manageable than if it comes out of control. There's always the challenge, though, of calling wolf. It's only, well, this is a 1 in 100-year event we're living through. We will see clusters of avian influenza cases in people all the time. We have been seeing them all the time ever since we've started testing for it. Only a tiny fraction will cause a global pandemic. So another thing is knowing how to balance that response in a cost-effective and sustainable way.
But that pandemic, if it comes, could be dreadful. I mean,
it's an interesting question about what the worst. So the thing, this pandemic has been difficult to control, just as 1918 Spanish flu was impossible to control, because the great majority of people infected only have mild disease, and a significant minority have no disease at all. They're asymptomatic but may still transmit, and that makes it a very difficult disease to control without imposing massive social distancing measures, as compared, for instance, with Ebola, which you might think is a scary disease. Universally causes severe illness. A third of people who get it die. But actually, that makes it more controllable. You can identify people who have the disease much more easily. You can isolate them much more easily. And so there is this interesting trade-off. Diseases, when they get beyond a certain level of severity, particularly if everybody who gets them, like was the case with SARS, becomes severely ill, are actually easier to control than diseases which are more cryptic in their presentation.
Is there a sweet spot of, because H5N1 seems to kill about 60% of the people who
I mean, so it's in the kind of Ebola category, and almost certainly if it became transmissible without changing what's called phenotypically, changing its severity, being as severe as it is, it would be a bit like Ebola or a bit like SARS. But it's certainly possible we could get a respiratory pathogen, let's just say, instead of coronavirus in the UK context, has at about 1%, killed about 1% of the people it's infected, unfortunately. I could certainly envisage something which killed 5% of the people infected and killed those people across a much flatter age distribution, just as Spanish influenza did. That's entirely possible and would still be a very difficult virus to control.
I think there's some key characteristics of the disease which are critical for sort of that scariness that Neil's just been talking about. If you take the MERS coronavirus, which, as Neil said, was also pretty horrific, about a third of the people infected died. But the key thing was that there was very little shedding before people became sick. And I think the problem would be with this virus, if it had that very high mortality, but had still shed for a few days before people became sick and transmitted in the way that this virus is, that's the really scary scenario. And I think that is something we have to be prepared for in the future, is a sort of a pandemic virus that does spread as effectively as this virus has, but still has a much higher mortality. And although it would be great if it was always the case that high mortality infections can be recognized early and isolated, I'm not sure we can be absolutely confident that that will be what happens next time.
What do you think about the relationship between these emerging zoonotic diseases and the sort of intensive farming of animals? That avian influenza, rips through close-packed poultry populations. Do we need to be looking at a demand for meat and the way in which meat is produced as sources of risk?
So I think it's a complicated picture. Paradoxically, it's the extensively reared, free-range poultry flocks which are most at risk of avian influenza. I mean, sort of meat and eggs I would typically buy, but the intensively reared ones, I mean, in battery farms, both in this country and actually in Thailand and Asia as well, tend to actually have very high biosecurity conditions. Of course, there's a problem if something gets into them, but they're not the principal risk. One of the bigger risks is just the energy intensiveness and the resource intensiveness of mass meat production, and the fact that rainforests are being cut down to plant plantations of crops in order, being used to feed cattle and chickens. It's that encroachment on wildlife habitats which brings us up against that massive viral reservoir, which is the rest of the global ecosystem.
Do you think
I think the other thing, of course, is that we've got an enormous number of people on the planet, and that number continues to increase. And the absolutely critical thing in transmission, as we all know from all that we've heard this year, is contacts between people. And so I think it actually increases the likelihood of further pandemics in the future, because there's just so many people, and travel is much better than it was in 1918. And so the seeding around the world of any new viruses is also going to be much easier. So I think that those factors are absolutely critical, and the biosecurity around that is also needs consideration. I like Neil, I'm not so sure that it's the intensive farming. It's perhaps more the contact with wild animals, where completely new viruses that we've not discovered before tend to be.
Do you think we should be much bolder than we have been in trying to take steps to stop this? Should we be looking for global treaties to completely end the wildlife trade, for example, and to end live animal markets and things like this? Because
it's things like bushmeat. I mean, Ebola epidemic. Let's talk about Ebola, which is a virus we know, but unfortunately causes catastrophic outbreaks on occasion. I mean, particularly the West African Ebola epidemic, which I worked on a lot. But that we don't know precisely what started it, but the bushmeat industry, which is basically the slaughter of primates of many different species and being sold for meat across the world, is both ecologically catastrophic in terms of wiping out species, but is exactly the worst sort of interaction between wildlife and humans from the point of view of disease. But it requires, I think, as Andrew stated earlier in another context, it requires engagement with those communities. I think global bans are in place, but in many cases, people are frankly slaughtering those wild animals because they have few other sources of either protein or income.
And another threat in the same category is the possibility of engineered pathogens, where if you're an aspiring superpower, say, or something like that, and you want world domination, or if you're a terrorist organization looking to wreak as much havoc as possible, it's fairly clear what you do. You try and engineer a virus, engineer the spike protein and so on, in the way we've been trying to do this year for good purposes, but you do it to create a virus that wipes out as many people as possible, and then you'd also immunize your own people against it, as depicted in lots of sci-fi scenarios over the years. I suppose it's a question for you, Dido, in terms of you're involved in setting up Joint Centre for Biosecurity in the UK. Is there anything we can really do again, to protect ourselves against that kind of scenario?
Well, I think if I can broaden the question a bit and say, I do think there is a lot we can do to set up the sort of institutional framework and skills to be looking at these long tail health security risks in the way that we look at other long tail risks, both financial and national security. So as we, the Secretary of State, Matt Hancock, announced on Wednesday, we're launching the UK Health Security Agency that will be, will take in the health protection work of Public Health England, NHS Test and Trace, and the Joint Biosecurity Centre. And there's an opportunity, a moment in time, to set that new institution up at a level as part of our national security infrastructure, and to treat it with that sort of seriousness. I couldn't be more pleased that Dr. Jenny Harries is taking on the role as Chief Executive. I think she'll be fabulous. But I think there's some really important things for us to think about as we do that. The whole world have become amateur epidemiologists in the last year. There's nothing more interesting to journalists, to TV producers, to all of us than health protection, health security right now. In a few years' time, that will go, that will wane. And God willing, actually, because there'll be other things for us all to be thinking about. And the danger is that we don't continue to invest and focus on health protection, health security. So one of the reasons for setting up the UK HSA as a separate entity is to make sure that there is a body that is solely focused on that health security and health protection agenda. It needs to be a core part of the overall public health family, because as we've been talking about today, health inequalities are something that binds everyone working in public health together, and it's hugely important it plays its role in that overall family. But I think it's important to have a dedicated space. And I know I've been a sort of boring economist on this panel, keep referencing back to financial services, but if you look at the role that the Financial Policy Committee plays and the powers the Bank of England acquired for financial stability coming out of the 2008 crash, creating a space only to look at the long tail risks on financial stability, as opposed to the here and now decisions that the Monetary Policy Committee takes on interest rates, for example. I think we've got to, yet they're both part of the Bank of England. It's important that we create that same sort of superstructure for health protection and health security. That's not to say that you can never be perfect, but I do think that it is possible with the right form of partnership working and much broader skill sets. That's one of the things we've definitely learned in the last year, bringing in these very stripy teams with different scientific disciplines and different backgrounds to keep challenging because the next pandemic won't be the same as the one we've just had. The next health security risk will be different, and it's important we create this institution whose job it is to be asking those 1 in 100-year questions to keep looking for us.
I think considering your question about the sort of the evil force in the world that's trying to release a pathogen, in the end, it comes back to the same response as it is to any pandemic threat, which is that it has to be underpinned by the science. And I think the last year has been a pretty astonishing public viewing of what can be done with the investment we've had so far in science. The fact that a genome sequence could be emailed on the 11th of January last year, before we even knew there was going to be a pandemic, and that could be then the starting material for vaccines, which are today saving thousands of lives. That's astonishing. Neil fiddling with his maths to try and predict what might happen next. I mean, that's astonishing science. I think we're still underinvested in these many different areas here in the UK, and yet we do quite well in that investment compared with many other countries. But I think in the end, the responses to the type of threats you're talking about can only be successful if we've got the academic and the life sciences industry already in place, ready to respond when the threats occur. Yeah. And I do think we've got more work to do, but we actually were not in a bad place considering where we've got to today.
I mean, do you fear the sort of technology you've been using to edit adenoviruses and so on falling into the wrong hands? Do you think we should treat it like nuclear technology, where we aim to restrict it as much as we can?
I would frame it slightly differently in that I think this year we've been rather like we've been in the space race, in that there's been incredible innovation around vaccine technologies. The really exciting RNA vaccines that we've all learned about how they work in the last year that could have many applications in the future. At this moment, there are 80 different vaccines in clinical trials, some of which will eventually become licensed and available for COVID, and about another 180 is still in the laboratory. So that's an incredible global effort, and I think we're going to reap huge rewards in the future from that, just as sending people into space. Whatever you think about the use of the money there, we are absolutely clear that trying to work out the solutions for that has been incredibly helpful, and for many other branches of the world since then.
Yeah, I mean, I agree. I think the risk from engineered pathogens can be overstated. I mean, there will be a long-term, potentially existential risk from it, but our current ability to predict the phenotype, how a particular virus with a particular sequence will behave, is still very limited, and we learn all the time. And so whilst we know enough about some influenza viruses to potentially do something, then and reverse genetics, as it's called, does pose something of a risk and has been often talked about in terms of the sort of experimental research which should be allowed around recreating certain sorts of influenza viruses and the containment levels of labs. I think accidental release poses a potential risk, but I think we are at least a few years, if not a few decades off the risk of intentionally engineered pathogens exceeding that from natural ones. I mean, I still think our biggest risk is from what's out there in the global ecosystem already.
Yeah. Okay, let's move now to questions from the audience. And here's a question for Dido. Can you say something about other bio risks that the Centre of Biosecurity has on its radar, I suppose, in addition to the obvious ones relating to pandemics we've been discussing?
Well, as we stand today, the Joint Biosecurity Centre was set up to be solely and single-mindedly focused on COVID. But my colleagues, brilliant colleagues in Public Health England, of course, work on the much broader landscape of other, both sort of biosecurity and other hazards to human health. And they will be a core part of the UK Health Security Agency as we establish it. And I think that is a question of taking the strengths from both of those worlds. What we have, as Andrew said, I couldn't agree more with what Andrew said about the need to make sure that we have this very open partnership way of working with academia, the sort of commercial life sciences, and our sort of public health protection, health security institutions. And I think we were in a good place as a country before the pandemic. I think we're in a much stronger place today than we were, that we've discovered the real power of working together in a crisis, and we mustn't let us the system sort of snap back into even limited silos. So my hope and ambition for the UK Health Security Agency is that across all hazards, we will adopt that same sort of deep partnership working between academia, the commercial sector, and the public sector, because that's at both a national and at a local level. Let's not forget, we've been talking mainly about pandemics today, but actually the job of health protection is on the ground with individual small outbreaks of well-established diseases. It's really important that work is done, and that we're in the same way working collaboratively across local governments and the public health system and the private sector. So rather than get into the specifics of individual hazards, I think it's important that we blend the sort of what's been the meat and drink of health security for decades with this sort of turbocharging that we've all learned how to do in the last year, and set something up that has the best of both.
Great. A question here for Andrew, I think. Do you think vaccines based on the viral genome, including both the mRNA and viral vector types, will be as effective for other new viruses as they have been for COVID? Would that technology work against pandemic flu, for example?
Well, I think there's work to do to evaluate all of those, but in that we already have understanding of the targets for some of the other viruses like flu viruses, there's no reason why the same types of technologies that we've seen across the board here in this pandemic couldn't be applied for future pandemics. The critical question is knowing which is the bit of the new pandemic virus that you need to use to make the right immune responses for protection. And that's going to be different. I mean, some of these may not be respiratory, although perhaps respiratory viruses are the most likely to cause pandemics, but not necessarily. And I think that's something which has to be looked at with each individual emerging virus that causes a pandemic.
There's a question also about new variants. In that, is it the case that each new adaptive variant that increases transmission, say, requires more base pair changes because, in a sense, the low-hanging fruit has been taken? And if that's true, should we expect new variants increasing transmission to become rarer and rarer because they're harder and harder to achieve? Or is that the wrong way of thinking about it?
There probably are limits to transmissibility, I should say, almost certainly. But whether this virus has reached that limit is less clear. I mean, it seems to be exploring quite a wide range of genetic options in the kind of genetic space. It's going, and as Andrew said earlier, I mean, we're seeing convergent evolution. We're seeing the same changes coming up again and again.
I mean, it's important to remember that we're all infected with coronaviruses as children, and those coronaviruses, the same ones, continue to give us colds as adults. So it's not as if most coronaviruses just disappear. And I think that's what I would imagine will happen here. And even going back to 1918, that pandemic flu virus stayed around for decades after that. It didn't completely fizzle out. It's just that enough people became immune that it wasn't continuing to cause pandemics. It just was causing seasonal flu.
Thanks. And there's a question for, I guess, for Neil, because it's really about scientific advice, that should there be permanent pandemic ethics committees with non-clinicians in the majority so that decisions can be made faster? I've been wondering about that myself, I suppose, that should there be ethicists involved more heavily in the advisory process?
And so I think there's some input from, I mean, ethicists have inputs in studies, but I think they have some inputs into, for instance, the 𝗖𝗢𝗩𝗓 subgroup of SAGE. I think, I'm not going to try and reflect on it too much, but I think we, as well as learning lessons from how the UK's government machine has responded to this pandemic, we need to learn lessons of how to further improve scientific advisory structures. And I'm sure 𝗘HSA will have its own scientific advisory structures as well. I think increasingly scientific advisory committees, though, are multidisciplinary and include people from both the social sciences as well as the natural sciences.
That was one of the other questions, in fact, from Sammy Peterson. Can social scientists contribute to pandemic preparedness and response? There has been this, it's a good LSE question. There has been 𝗖𝗢𝗩𝗓, as you say, Neil, that's been this behavioural science committee. Do you think there is I suppose, a richer role? Should social scientists actually be around the table with your?
I think they have been, and they've been involved in SAGE, and well, Baroness, said earlier in this meeting around the importance of understanding, for instance, behavioural determinants, economic determinants of isolation of individuals, and do people self-isolate. I think they've had, behavioural scientists have had major inputs into multiple aspects of the pandemic response.
Yeah, I think that's absolutely right. There's been phenomenal contribution from behavioural scientists, both sort of in their academic roles, but also actually operationally side by side with the teams as we've developed products and programs. We've tested them, used all the sort of behavioural insight techniques to develop the communication campaigns. I think it's been a time of both the natural sciences and the social sciences coming together very effectively.
I was just going to add that we've understood, I think, quite a lot over the last few years about vaccine hesitancy where it is, and perhaps some of the causes and the features of it. But what we really need now to be doing is evaluating different interventions to try to communicate better, work out what actually is needed. And that's a whole area of behavioural science, which is, I think, and becomes urgent in the years ahead.
Thanks. And there's a question for Neil and Andrew. Do you really think the next pandemic is unlikely to happen before 100 years or so, or could a new pandemic happen at any point? I guess when you say 1 in 100 chance,
yes,
you don't really mean we've got 100 years.
I mean, there's been a lot of work in the last 20 years on trying to quantify the risks. But yes, it's more better saying that every year there is a 1 in 100 risk of a pandemic. I don't know what I'll do if it is, but there is a 1% risk probably next year. We'll have we could have a lethal flu pandemic. It is not like you have to wait 100 years. It's just that it is a relatively rare event, thank God, but it can happen at any time.
Perhaps the way I'll answer this, and I'm sure Dido and Neil will feel the same, is that I'd rather we don't have another one. So
yes.
Please, can we not have another one in my lifetime?
It's a good point, isn't it, about how you communicate risk? Because if you say once in 100 years, people feel reassured and, oh, I can relax then. But actually 1% every year of a potentially apocalyptic event is not great. And we should probably be doing quite radical things to reduce that risk.
It's why focusing on managing long tail risks is something that you have to do in a dedicated way. Because it challenges the human brain too much if you blur it with what you actually expect to happen tomorrow.
Right, and there's a question of whether politicians are actually that well placed to think about these risks, because the structure of democracy seems to push politicians to thinking about the short term rather than the long term.
I mean, indeed. I don't have any concern that even for the next decade, we will learn all the lessons we can, we'll improve preparedness, politicians will remember, maybe even 2 decades, but I completely agree in the long term, for societies to have that long-term institutional memory about this event, which actually shapes our preparedness and capacity into the indefinite future, will be a much harder thing to achieve.
And I'm going to give a slightly more optimistic view in that over much of the last decade, I've been involved in vaccine policy in the UK. Not COVID vaccines, but other vaccines. And I've been astonished by the responses of government to long-term strategies around vaccination, which have completely and consistently followed scientific advice over that, and doesn't seem to have been short-term in the view. So I think that perhaps that it isn't always the case that things are short-term and around the next election cycle.
It's a question here for Dido. How far are we in terms of coordination for biosecurity on a European level, and what should the next steps be? I suppose implicitly there might be a reference to Brexit in that question, and whether that's actually created new problems for coordinating across Europe on biosecurity.
Well, I think I'd defer to Andrew and Neil on the scientific collaboration. What I would observe from a distance is that there's been phenomenal collaboration, both sort of clinically and scientifically, and from a sort of technocratic level, that not just at a European level but at a global level, that the different communities have been sharing knowledge and expertise and data and insight in real time. And we wouldn't have got to the point we have so far without that. That said, I do think that part of the learning coming out of this is to say not just what it's been a theme of this whole discussion, that we can't sort of tackle health security as an island on our own, and that stepping back as God willing, over the course of the next 12 months as we come out of this, and say what are the right institutional ways of embedding that collaboration as the world gets back to normal, is one of the important things that we should all reflect on. I think it's probably a bit too early to reflect on that yet. I think the working collaboration through the crisis is phenomenal. But we should be thinking, no, sorry to be the broken record, just as at a global level for financial stability, the Financial Stability Board was formed after the 2008 crisis. It wasn't that there wasn't no coordination before in financial services, of course there was, but it's a moment to reflect and reset, which I hope we will take.
I think from a scientific perspective, there's been very good discourse, in my view, with scientists across Europe. At public health level, I've been discussing with European CDC, and I know Public Health England have been very closely involved with discussions with them. The regulators, the European Medicines Agency and the MHRA are talking regularly. So I don't see major barriers that are there for some of those between those institutions which we so desperately rely on.
Great.
I agree. I mean, the level of scientific, technocratic, I think, is discourse and has been remarkable. And just within the research community, I mean, there has been a paradigm shift in how biomedical research is done and published, in particular, during the pandemic. I mean, we have moved to a situation where people put out their data and results in real time on preprint servers before even waiting for traditional journals. And I think that will be a long-term benefit. I think where there has been arguably, benefits there would have been more benefits to greater international cooperation is really at the interface of science and policy. I mean, individual countries have responded in very individual, not nationalistic, but kind of nationally focused ways, and not necessarily learned as many lessons from each other as they might have done.
Yeah, thanks. And there's a question on that, in fact. Could we have rolled out COVID-19 vaccines worldwide far earlier if we'd had better global regulatory convergence? And should that be a priority area for future pandemics? And what might such a global structure look like? I don't know if you have any thoughts on that, Andrew.
Yeah, I think from a regulatory perspective, within a couple of months, I only know in detail about our vaccine, but there's 70 countries have approved it through COVAX. It's available to 140 countries. So that to me doesn't feel like there's a problem with the global connectivity of regulation. We've got about a month between the first regulatory approval and the major one being European Medicines Agency that fed into the WHO decision. So I don't think that is something which has caused a major slowdown. The biggest problem with vaccine distribution is supply. That it normally, to upscale manufacturing, takes years. And I've seen this happen with multiple products over the last 25 years. And it's really hard to make these biological materials. It usually takes several years just to get your plant to make reliable numbers of doses at scale. And we're seeing that at the moment in the current battles that are going on with the supply of vaccines in Europe, which is entirely related to getting yields up to a level that meets the demand. And I think this is a problem even with something like our vaccine, which is being manufactured in 20 sites to try and protect that global supply chain, but that's still not enough. I mean, it's never going to be enough for 7 billion people. And so I don't think it's a regulatory thing that's holding up distribution. It's much more around having enough vaccines and enough doses that can be made.
Thanks. There's a question that's probably for Neil, I think, that what do you think the likelihood is of England needing another lockdown despite the vaccine rollout? And what sort of factors are scientists looking at to determine whether that will be needed?
I very much hope we don't. I think I've been encouraged by government policy in the last few months and the cautious route out of lockdown, which will be driven by what trends we see. I mean, currently the trends are positive. I mean, they're looking optimistic. I mean, we are seeing a slight uptick in infections, but that's within what we expected to. I think we clearly want to move to a situation where we're managing this virus with vaccine, frankly, rather than with economically, socially costly non-pharmaceutical interventions. Am I sure we will, be without we'll never need to use them again. They're not completely. I mean, the biggest threat at the moment, as Andrew highlighted, is from things like the South African variant, which probably would compromise vaccine efficacy, but it would still probably have some residual efficacy, but it might compromise it enough to risk, if transmission took off, significant additional mortality. I think the best way of mitigating that is what's being done at the moment, which is updating the vaccines to cope with that new strain.
Thanks. And there's a question here about vaccine rollouts that I think is for Andrew, in that, well, we've seen in Britain a very successful one on the face of it, and some troubled times in the European Union. I've heard it argued, says Jordan Warner, that the biggest obstacle to getting a new vaccine out is that bureaucrats know they'll get blamed for any adverse effects, so they're reluctant to do anything that could be seen as too hasty. I guess that's reflecting some of the discussion about the precautionary principle and so on, when several European countries suspended the AstraZeneca vaccine. Do you think, I mean, so Andrew, do you think that governments are sometimes too precautionary about adverse effects of vaccines?
I mean, I think it's really important to have very good safety monitoring in place. And I think we're fortunate across Europe in having regulators who are absolutely monitoring that, whether it's the MHRA or the European Medicines Agency, collecting anything that happens to someone after vaccination and having a look at those events in detail to work out whether things are more common or not. And really that's, in my view, is what we should be relying on, those strong institutions that we have that give us advice. And personally, as a recipient of vaccines, I want to have absolute confidence in those organisations to do that. It is difficult because there's also in each country a responsibility to that population that has to take into account who's being vaccinated, what the supply is at that moment, and so on in making their decisions. I think the risk of having sort of the on-off approach to vaccination is the impact it has on public confidence. And I think that is something which has to be balanced very carefully against the absolute requirement that we have to have good safety monitoring to help make those decisions. And I think it is actually our institutions in the regulators who are best placed to provide advice on that.
Do you disagree with that decision that was made in some European countries to suspend the AstraZeneca vaccine for a few days?
Well, I think from a policy perspective, it's up to those countries to make their decisions. What I'm saying is I think it does risk confidence in programs if you have this on-off approach. I mean, clearly, if there are significant safety signals where that risk-benefit equation, which is done with any drug or vaccine, starts to balance in the wrong direction, then you have to act. And we've seen over the decades some drugs which have been withdrawn because it turns out that there are particular risks which then outweigh the benefits of that product. But here we're dealing with a pandemic virus that, across the European region has killed nearly 1 million people, the WHO region. And that is something which really has to be taken into context with any concerns that are ever raised. And so we have to try and look at that. And we're, as scientists, not the best people to do that. We don't have all the information at our fingertips. It has to be the regulators who have that responsibility for safety.
So here's a good question that I will put to Dido. Is there a conclusion that you think policymakers might draw from this pandemic, which in fact they shouldn't, because in different scenarios it could lead to big mistakes?
That sounds like an Oxbridge entry question.
I know it does, doesn't it?
I think and very hard to answer in the specific. I mean, a number of people have sort of alluded to this in the chat already. The danger is that we only look backwards and that we learn all the lessons from this specific virus and this specific moment in time. And actually, that would be a huge mistake. That's obviously a huge mistake, but it's much easier to say it than it is to avoid doing it. And there are ways and means of sort of forcing policymakers to think through different scenarios. So that as we come out of this, forcing ourselves to really both model and rehearse at a local and a European and a global level for very different scenarios, big and small, will be really important, because unconsciously, as the questioner suggests, the impact of COVID will be seared on this generation's decision makers, and we will find it very hard to shift our unconscious bias unless we are forced to actually put ourselves into different scenarios.
It makes me think about the swine flu pandemic, actually, that Neil, you were very heavily involved with, where it turned out to be quite a lot milder than initially thought. And then one might think perhaps policymakers learned the wrong lessons there. They learned, one should be relaxed and not rush into anything. Do you think that was the case? And do you think there's also a danger of learning the wrong lessons from this one?
So I was concerned that would be the wrong lesson learned from 2009 and swine flu pandemic. But actually, I didn't see any evidence of that happening in the UK policy community. I think they had quite a nuanced understanding. I mean, inevitably, anytime a new influenza pandemic starts, it is a major issue, regardless of what the severity is. And then I think the key lesson we learned then, scientifically and in terms of policy terms, is quite how difficult it is to assess a threat early on, and the magnitude of the threat. And thankfully that lesson was learned, both from a technical and from a policy perspective, for COVID. So yeah, I think maybe globally in some areas, some countries probably relaxed a little, but I don't think that's an accusation could be made of this country.
I was involved in vaccine development in 2009, and I certainly don't see any hesitation that there's been as a result of that experience back in 2009. I think everyone still went off at full speed. I think, as Neil says, there was definitely a period in January and early February where there was still a view, oh, this is just like seasonal flu, we don't need to worry. And I think that's the bit that perhaps it took a little bit longer for people, for the penny to drop. I think there's exactly as Neil was describing, to really set off in the direction that then resulted in the lockdown just over a year ago. But I think it was a very difficult time when it still wasn't absolutely clear, and it's having certainty of the data is so difficult at the beginning.
Do you think there's a danger of the pendulum actually swinging too far the other way and governments becoming too lockdown happy? Because lockdowns, of course, have terrible costs.
I don't actually think there is a risk of that. I think no government wants to impose a lockdown. And the problem has been really the other way around, that I commented earlier that it's sad that those lessons were not learnt by the autumn, of the importance of responding early to exponential growth. But that partly reflects that political reality.
And I think we're seeing that in other countries at this moment, where they're struggling with getting into strict lockdowns again. In many countries around the world that are seeing big increases in disease because of the economic impact. And of course, there are some countries where that lockdown causes people in the community to starve. And that's really difficult, where you've got very, very poor countries where lockdowns have these terrible implications.
Andrew, are there any lessons you fear that policymakers will take from this when they shouldn't?
Oh, that's a good question. I'm not sure that is the case. I think that all of the policy decisions are incredibly difficult to make. And I think Neil's really put that across very clearly. Balancing the public health agenda against political pressures that they all face, and the financial consequences of doing it, the impact on children and education. They have to balance all of that in making their policy decisions. And the rest of us are much more focused in our silos on health usually, and that is always much more clear cut than the policy decisions. So I think for me the key thing that has to come out of this is good investment in the science, so we're well prepared for next time. And I'm troubled in the last week by the cut in the overseas development assistance budget, which an absolute critical part of what has been our pandemic preparedness. So having this portfolio of research around surveillance and vaccine development globally, which is absolutely critical for why we were able to respond this time.
And linked to that is the data. As Andrew said, I think the lessons of every crisis of every shape and form is that taking decisions when you don't have data is phenomenally difficult. And that's what it was like for decision makers this time last year. It's what it was like when decision makers were deciding whether they should or shouldn't rescue Northern Rock in 2008. And so putting in place the surveillance and data infrastructure across the broad panoply of potential health threats, that's one of the things that we mustn't forget to do, because actually that will then enable future policymakers it will just make those really difficult judgments easier if you've got the data upon which to decide.
So we're out of time, essentially. There's just time for any concluding remarks you might have. I suppose if there's one thing you'd like to say to the LSE students, the next generation of people who will inherit these problems of trying to respond to pandemics, about what we can learn from your experiences of dealing with this one, what would it be? Should we start with Andrew?
Well, I think at the beginning, the most important thing is to not to hesitate. Don't hesitate in getting things moving, because I think that's the biggest risk. But whether that's providing the finances that are needed for getting the systems in place, whether it's vaccine development or surveillance, to not hesitate in that process, because I think, as we've seen, weeks will absolutely cost lives, and so it has to be everything has to stay moving as swiftly as possible.
Dido?
To build on that, successful decision making in a pandemic requires inclusivity. It requires a panoply of different skills and experiences, and creating that environment where the different scientific tribes can speak truth to each other and to power is essential to get the best possible decision making under pressure.
Neil?
I was actually going to say something very similar to Dido. I mean, thinking of your LSE students, then first of all, it's a very exciting time to be going to LSE. I think the last year has shown that we need interdisciplinarity, we need multidisciplinary teams working together, and the importance of putting that within a kind of analytic and systems framework for making efficient decisions. And I think what those students will be doing in LSE and what LSD does day in, day out in terms of its research and teaching will be generating a kind of cohort of students very well equipped to deal with those challenges.
Great, thanks very much. I mean, on my own behalf and on behalf of the LSE as well, I'm just incredibly grateful for you giving this time to us and reflecting on your experiences and answering so many questions. It's been fantastically insightful. Thanks to all of you. And I'll hand back now over to Joseph. Can't hear you, Joseph.
Sorry, it's a continuing problem. Yeah, thank you very much to everyone for what I think was actually a deeply insightful discussion, and that has equipped me and certainly our audience as well with a new, more informed perspective on this, what is undoubtedly the biggest issue of the day. So up next then, we're going to be talking about a man-made threat that's been much, much less prevalent in the public consciousness. In our panel, Rage Against the Machine, The Perils of AI. This is going to be taking place from 4 o'clock till 6 o'clock UTC, and it's going to be featuring panelists Stuart Russell, Jade Lung, John Tallinn, and Max Tegmark. We're going to be asking them, what is the problem with the current public understanding of artificial intelligence? And we're going to be asking this in the context of how it can actually present a threat to the entirety of the human species. And then we're going to be considering, do we have appropriate safeguards in place to ensure that actually the incentives of super intelligent AI align with our own? So I thank the speakers once again for this excellent discussion. I'll see you later on.